continue the spirit of.
Sir, sincerely tell you, Mohan Maharaj not started, sir. Sincerely telling you, it's a team of Vizag team started, sir. Nothing.
Yeah. Everybody's effort. Yeah, it is everybody's effort to make the critical care to be whatever the knowledge to improve all the who are working in the critical. That is my motto is should be a good knowledge and should be ultimately the benefit to the patient and also the hospitals who are taking as a we are working for the hospitals. I hope everybody accept it. And most important, the knowledge. Knowledge is the most important. That's why to percolate the everybody is having some people have a good knowledge that should be given to the other people, other juniors and the students, and should be whatever knowledge should be shared to the other people. Yeah, with these few words, I welcome all the delegates and Dr. David and Mohan Maharaj, they can continue this class.
Thank you, sir. Sir.
Please start, Mohan Rao.
Sir, good afternoon. Welcome to the second session of the VICC, Vizag Intensive Care Critical Care Studies. I hope last session went very well and most of the doubts also clarified. I request all the participants to type their questions in the chat box and mute their mic during entire session. And today's topic is in acute chronic liver failure. Presenter is B. Jasmine. She is a student of IDCCM, doing her IDCCM in Seven Hills Hospital under Dr. Kuchalavu sir. And today's moderator will be Dr. David from Pinnacle. He is a HOD and of the critical care services of Pinnacle Hospital. He is having a huge experience in critical care, particularly interested in liver transplantation and neurocritical care. With this, I request Dr. David to take over.
Thank you, sir, for the nice introduction. We Pinnacle Hospital started liver transplantation and successfully done the 3 liver transplantation, and we had some complications, but managed very well with a good outcome. Some experience of liver transplantation and management of acute liver failure and acute and chronic liver failure patients, how to approach and how to manage and how to go for the liver transplantation and post liver transplantation complications, all very important in critical care settings. So now I request Dr. Jasmine, who is the IDCCM student in Seven Hills Hospital. I request Dr. Jasmine to start the presentation.
Okay, sir. Good afternoon to everyone.
Share screen kotti adi open cheyi presentation.
Okay, sir.
Class lo untaru. మీరు పక్కన ఉన్నారు చూడండి.
ఓకే, ఇది స్లైడ్ షో మోడ్ లో పెట్టుకో. Right. Continue.
Good afternoon, everyone. Today, my case presentation is on acute on chronic liver failure. My moderator is Sir John David, HOD of Critical Care Department, Pinnacle Hospital. Coming to case discussion, a 48-year-old male patient, laborer by occupation from Gopalpatnam, came with chief complaints of yellowish discoloration of eyes since 3 weeks, abdominal distension since 3 weeks, abdominal pain since 3 days, fever since 3 days, altered sensorium since 1 day. History of present illness, yellowish discoloration of eyes and urine since 3 weeks, gradually progressive in nature, not associated with itching, have not taken any treatment. Abdominal distension since 3 weeks, insidious is in onset, uniform, associated with bilateral lower limb swelling, pain abdomen since 3 days, diffuse, continuous, constant, severe, not radiating, associated with nausea, loss of appetite, passed last to 3 days back. Fever since 3 days of high grade, intermittent in nature. Altered sensorium since 1 day in confused state. Last alcohol intake 3 weeks back. No history of melena. No history of melena, bleeding, loose stools, or any history of drug intake. No history of cough with expectoration, no burning picturation, and no decrease in urine output. Past history, one case of chronic liver disease, alcoholic liver disease, diagnosed 1 year back, admitted 1 year back for upper gastrointestinal bleeding, for which endoscopic varicose band ligation was done. Patient continued taking alcohol after hospitalization, not a known case of hypertension, epilepsy, and asthma. Family history is nil significant. Personal history, patient is alcoholic since 20 years, taking
No,
daily.
Jasmine.
Sir,
You mentioned patient continued taking alcohol after hospitalization means patient is taking alcohol in the hospital.
no, sir. After hospitalization, when he was discharged, he's
You have
again
to
start.
mention
He
clearly.
usually,
After hospitalization means when after admitting in the hospital, patient started drinking again. Okay.
okay, sir.
Continue.
Alcoholic since 20 years, taking daily of 130 to 150 grams per day. Is a non-smoker, takes mixed diet, no treatment.
Again, I have a doubt that you have clearly mentioned 130 to 150 grams per day. But how did
Yes,
you
sir.
calculate that amount?
Sir, actually, he is taking alcohol in the form of whiskey, sir. One drink usually contains 10 grams, sir. 40 ml of spirit, which contains 40% of alcohol, sir. Approximately, he is taking 12 to 13 drinks per day, sir.
Drink means how much ml? One drink you are telling. One drink means how much ml? Total 13 drinks you mentioned. 13 drinks means how much ml of whiskey?
30 ml means 40% of alcohol, sir. 40 grams in 100 ml, sir.
40 grams in 100 ml.
Yes, sir.
Okay. Okay, continue.
Shall I continue, sir?
Yeah.
On general examination, patient is conscious, confused, malnourished, icterus is present, pedal edema is present, no palar, cyanosis, clubbing, and lymphadenopathy. Vital signs, pulse rate 110 per minute, regular rhythm, normal volume, no radioradial delay and no radiofemoral delay. All peripheral pulses were felt. Blood pressure 100 by 60 mm of Hg taken on left upper limb in supine posture. Respiratory rate is 28 per minute. Temperature is 101 degree Fahrenheit. Sugars are 94 mg per dl. Urine output 40 ml per hour, and which is high colored. On systemic examination, on abdominal examination, on inspection, abdomen is distended, midline, and averted umbilicus moving with respiration. External genitalia are normal. On palpation, diffuse tenderness on superficial palpation, unable to palpate liver and spleen, lymph nodes due to tenderness. Abdominal girth was 112 centimeters. On percussion, shifting dullness was present. Auscultation, bowel sounds were heard. Other systemic systems examination, cardiovascular system, heart sounds, S1 and S2 were heard. Respiratory system, normal vascular breath sounds, no basal crepitations. Examination, patient is conscious, confused, and GCS is 14 by 15, E4, V4, M6. My professional diagnosis is acute and chronic alcoholic liver disease with ascites, spontaneous bacterial peritonitis, and grade 1 hepatic encephalopathy. Day 1 investigations, hemoglobin was 9 gram per DL, PCV was 27%, total WBC count is 15,000 cells per cubic mm, differential count neutrophils were high, 90, platelet count 75,000 cells per cubic mm, ESR raised 50 mm in first 1 hour, RFTs, blood urea, creatinine were normal, calcium 7.8, magnesium 1.8, and phosphorus 1.9. Serum electrolytes, sodium 128, potassium 3.6, chlorides 92, prothrombin time 14, activated prothrombin time 41, INR 2.1, blood glucose is 90, blood group typing is O positive, liver function test, total bilirubin is 9, direct bilirubin is 6, SGP serum glutamate pyruvate transaminase, alanine transaminase is 292, serum glutamate oxaloacetate transaminase, aspartate transaminase is 383, total proteins are 4, serum albumin 2.2, arterial ammonia scent, amylase and lipase seems to be normal, 60 and 50, serum LDH levels 600, viral markers HIV, HBsAg, HCV are negative, scrub typhus, dengue, QBC for MP is negative, ABG is showing metabolic acidosis, procalcitonin, blood culture sensitivity, urine culture sensitivity, ascitic fluid culture sensitivity, gram stain were sent, ascitic fluid analysis showing differential count, polymorphs of 400, LDH levels 500, proteins of 1.3, gram stain showing gram-negative bacilli are present, SAG gradient, serum ascitic albumin gradient is 0.9, chest X-ray is normal, ultrasound abdomen showing hepatomegaly, irregular outline liver surface, splenomegaly with moderate ascites, 2D echo was normal with ejection fraction 60%, managed with initially Riles tube was placed, intravenous fluids DNS 75 to 100 ml per hour is started. Arctic feeds initially we started 25 ml per hour. Antibiotics third generation cephalosporin, injection taxim, cefotaxime 1 gram IV BD started. Injection pantoprazole 40 mg IV OD. Injection vitamin K 10 mg IV OD. Injection thiamine 200 mg intravenous BD. Injection albumin 1.5 gram per kg per day on day 1. Lactulose 30 ml QID through Riles tube. Tablet.
Sorry, ma, Jasmine.
Sir.
Just a minute.
Okay.
David sir. కొంచెం డిఫరెన్షియల్ డయాగ్నోసిస్ కానీ కొంచెం ఏదైనా ఉంటే కొంచెం చెప్పండి సార్. అంటే మొత్తం చదువుకుంటే వెళ్తుంటే మధ్యలో మీరు ఉన్నారు కదా, మీరు కొంచెం చూడండి.
ఓకే
సరే సార్.
Go back to your diagnosis.
Please continue, ma. Yes.
Okay. So your provisional diagnosis acute and chronic liver disease with ascites and spontaneous bacterial peritonitis.
Yes, sir. It's grade
1 hepatic encounter.
Hepatic encounter.
So,
yes, sir.
How do you know that patient is having SPP?
Sir, patient is presenting with a fever of high grade, sir. On palpation, severe tenderness is present, sir. Those are and is having abdominal distension since 3 weeks, sir. So when probably of ascites, it's impending infection causing spontaneous bacterial peritonitis.
You will put other than this.
Sir, we can go for acute viral hepatitis, acute any toxic hepatitis, drug hepatitis, any cholestasis, cholelithiasis, and acute fatty liver of pregnancy.
Patient is having acute alcoholic liver disease, chronic alcoholic liver disease. So what is the again why patient developed acute fatty liver again? But in this patient, what is your differential diagnosis? I am asking.
This patient acute viral hepatitis, autoimmune hepatitis,
Already
any
patient is having
acute
CLD, alcoholic CLD, when acute decompensation. Why you are
Yes, sir.
telling all this autoimmune hepatitis and acute fatty liver? This patient is having
the
1 year back, he diagnosed to have chronic liver disease
alcohol.
presented with the decompensation of
Yes, sir.
NKP. Okay,
Yes.
right.
He
Your other viral illness, bacterial infections, maybe patient is having urinary tract infection.
tropic.
Patient is
Yes,
having
tropical diseases.
Yasmin, Dr. David question is, what are the precipitating causes for a CLD patient going to acute liver failure? What are the causes?
Precipitating
Then you can
factors
make those
is
are the differential diagrams.
okay, sir.
What are the
Main
different
precipitating
causes?
factor. Sir, main precipitating factor is alcohol, sir. He was advised to stop alcohol, but he's taking still. Main precipitant is alcohol. Next, any viral infection it may cause, sir.
Any infections, not only viral.
Any bacterial tropical diseases can also cause, sir.
Any other?
Any traumatic maybe also can precipitate, sir.
Traumatic. What traumatic?
Main is the bleeding. Bleeding is the most important.
Yeah,
In
not
your
traumatic.
patient is not there. Normally, the another
Okay.
cause is the peripheral bleeding.
Upper G. Yes,
Yeah.
upper G.
Your patient is not different, but what are the causes? What is asking? What are the causes of CLD patient causing acute liver failure?
Precipitating factors to worsen the decompensate the chronic liver failure to acute liver failure. Okay,
Okay.
right. Continue.
What is the definition of ACLF?
ACLF, two definitions are there, sir. Asian Pacific definition and European Society definition. Asian Pacific definition defines that when there is hepatic insult or presenting in the form of liver dysfunction of bilirubin more than 5 milligram per DL and 5 more than 1.5, complicated within 4 weeks with either ascites or hepatic encephalopathy with previously diagnosed liver disease or without previously diagnosed liver disease, sir. Extrahepatic organ failure, generally this definition doesn't include, sir. In European, it is a syndrome. Already patient will be having liver cirrhosis with complicating organ failures involving kidney, like acute renal failure and encephalopathy, variceal bleeding, extrahepatic organ failure they included, sir.
Good.
These are the main.
Yeah, good. Is that is the differentiation feature between the ACLF and decompensation of the chronic liver disease. What is this hepatic encephalopathy grading, Amma? What is you name it, that one? How many grades are there?
Sir, there are two types of grading, sir. West Haven grading and modified Parks and Smith grading, sir. In West Haven grading, we start with grade 1 to grade 4, sir. In Smith's, we'll start from 0 to 4, sir. In grade 1, patient will be in euphoria, anxiety, very mildly disoriented. In grade 2, patient will be lethargic. He'll not having attention to subtraction, and disorientation will be there, sir. In grade 3, patient will be in semi-stupor state, and he'll be in a state where he'll respond to the verbal stimuli, sir. Grade 4, patient is in coma. He'll not respond even to painful, verbal or painful stimuli, sir. Parson includes the same, but 0 will consider as normal patients, sir.
When you are going to intubate, in which?
In grade 3 and grade 4 encephalopathy, we will intubate the patients, sir.
What type of acute hepatic failures you see?
Sir, David sir, మీ వాల్యూమ్ కొద్దిగా లోగా ఉంది సార్. మైక్ వాల్యూమ్.
How many types of acute hepatic failures?
Acute hepatic failure is divided into 3 types, sir, according to Ograndis classification. Hyperacute, acute, and subacute. When encephalopathy occurs within 7 days of jaundice presentation, we'll say it as hyperacute, acute liver failure. And acute or fulminant means when the presentation will be from 7 encephalopathy presentation will be after 7 days to 28 days of jaundice onset, sir. In subacute, from 28 days to 12 weeks, we'll consider subacute, sir. Subacute liver failure.
Okay. What are the etiological factors, etiology of fulminant hepatic failure?
Sir, various types, infectious viruses like hepatitis A, B, C, E, and herpes simplex virus, cytomegalovirus, varicella zoster virus, and drugs like acetaminophen.
Hepatitis C virus will cause fulminant hepatic failure.
C doesn't cause, sir. A, B, D, E.
Okay.
Next, drugs like paracetamol, anticonvulsants like valproate, antibiotics like tetracyclines. Next, drug abusers act as when they take cocaine. Next,
what is the anesthetic drug causing hepatitis, acute hepatitis?
Halothane is the main inhalational agent causing.
What are the drugs routinely used in ICU causing hepatitis?
Routinely using.
Okay. What are the drugs you are using in ICU causing hepatitis? You can differentiate the antibiotics, anticonvulsants. You name the drugs which are causing hepatitis.
Paracetamol in toxic doses is the main drug causing hepatitis, sir.
How much paracetamol dose is causing hepatic failure?
More than 4 grams per day, sir.
More than 4 grams. If somebody is taking 5 grams, will he produce hepatic failure? What is the toxic dose of acetaminophen to produce hepatic failure?
10 grams, sir. More than grams per day.
More than 10 grams per day. Okay. So what are the other drugs like anti-tuberculosis? What anti-tuberculosis drugs is
sir, anti-tubercular drugs like isoniazid, rifampicin, pyrazinamide, those 3 will cause liver failure, sir. And NSAIDs are the main drugs causing liver failure, sir. Next, other diseases like Wilson's disease, autoimmune hepatitis. These are also the acute fatty liver of pregnancy, HELP syndrome.
right.
Rice syndrome in children.
Okay.
David sir, one question they typed in the chat box. To the Jasmine, what is the usual natural course of DCLD? This is from Achyut.
Sir, decompensated liver cirrhosis, it usually presents with ascites, encephalopathy, variceal bleeding. Where we'll go, where it is irreversible state, we should go for only liver transplant, sir.
So can you explain the pathophysiology of each one, the complications of decompensation for liver disease? You mentioned encephalopathy,
Okay, sir.
SBP,
Okay.
ascites.
Okay,
No,
sir.
Jasmine, what the Dr. Achyut question is, how to differentiate between decompensated liver and acute liver failure? What is the difference?
Sir,
What is the difference? Decompensate ki acute liver failure.
Acute liver failure. Sir, acute liver failure may occur on normal liver, sir. But decompensated cirrhosis, already patient will be having liver disease previously. On that, on aggravation of precipitant factors, it may call a compound.
No, that is not the correct. I'll tell you. Decompensated liver is what
Yes,
you are
sir.
talking is correct,
Okay,
but the acute liver failure in a chronic patient and acute liver failure is when any organ failure is called acute liver failure. Any 1 or 2, 3 organ failure is called acute liver failure. Decompensated liver is never have an organ failure.
Yes,
Only
sir.
jaundice
Okay,
will
sir.
increase or encephalopathy maybe grade 1 will be there. Some maybe
Yes, sir.
bleeding disorders will be there, but not by failure, kidney failure. Kidney maybe creatinine may increase, not going to failure. Or patient not on
Okay.
mechanical ventilation. Any failure is called acute liver failure in a chronic patient. Decompensation, not a failure, it is only decompensation.
Okay,
Okay,
sir.
go ahead. Thank you.
Sir, complications usually spontaneous bacterial peritonitis pathogenesis is patient will be having a decreased gastric motility, sir. So the organisms which are present they permeate through the wall and enter into the lymph nodes. From there, the already collected fluid which is present in the peritoneal cavity, these organisms will enter into the ascitic fluid and resulting in the spontaneous bacterial peritonitis, where we should exclude already any perforation. Surgical cause should be excluded, sir.
So what are the biochemical tests to rule out SBP?
Main will do ascitic fluid analysis, sir, where polymorph nuclear cells more than 250 cells will be present, sir, and we'll send for culture whether any organism which is present according to the culture will give antibiotic.
Only the culture, but what are the analysis of the ascitic fluid?
We'll
Yeah, you can
we'll
say that
see.
SBP.
Sir, sag gradient is the most important thing we should do, sir, which is difference between serum albumin and ascitic albumin, sir. When the gradient is less than or equal to 1.1, it will go mostly less than 1.1 infectious etiology, sir. More than 1 or equal to 1.1 is portal hypertensive features will be there, sir.
I think it is not less than, it is more than 1.1. More than 1.1 is a diagnostic feature of the SBP. And ascitic protein should be less than 1 gram per deciliter.
Less than, yes, sir.
Not SAG. I am asking the SAG ratio of the serum and ascitic. So only ascitic fluid protein albumin should be less than 1 gram per deciliter. That is the diagnostic. And as you said, 250 cell count. And what is the LDH level to differentiate between the primary and secondary bacterial peritonitis?
LDH will be more than 2/3 of the serum LDH, sir.
Okay. Sugar, glucose values?
Sugars will be less than 50, sir.
50. So then you can go for the culture sensitivity report. Culture sensitivity takes time to grow the culture. What are the commonest organisms in SBP?
Most viridans, streptococci, E. coli.
You said already this is the because of the bacterial transportation of the bacteria, gut bacteria into the ascitic fluid causing SBP. What are the bacteria present in the gut?
Normally,
is called enterobacteriaceae. Enterobacteriaceae. Bacteria present in the gut. So what are the enterobacteriaceae?
E. coli,
E. coli ఒకటేనా?
Bacillus species.
Huh? Okay, we will come there. So because sir,
David, another question that I put in the chat box from Sai Rama. Jasmine, how do you perform ascitic tap? And are there any contraindication for doing the ascitic tap?
when you will do ascitic,
Ascitic tap we will do usually first we mostly right and lower quadrants of right left lower quadrants are usually preferred for tapping, sir. Actually usually we only for symptomatic relief will advise ascitic tapping. It doesn't improve the disease prognosis, sir. Only for symptomatic relief we'll do, sir. But providing albumin infusion accordingly we'll tap, sir.
when how
Yes.
you will give albumin infusion for paracentesis?
Sir, if we take 2 liters, we are planning to do, we'll transfuse almost 12.5 gram of 25% or 20% albumin, sir.
For every time you take more than 2 liters, you will give albumin. What are the guidelines says?
Depends.
Till it is not the 2 liters, more than 5 liters, or patient is symptomatic, then only, and patient is having encephalopathy or varicose bleed, then otherwise less than 5 liters, albumin transfusion is not required. Okay.
Okay,
So what are the
sir.
complications of paracentesis?
Paracentesis, infection is the main cause, sir.
Infection. Okay.
Once we will do tapping again, the chances of reaccumulation is the same, sir.
Okay.
Sir,
Okay, hypotension. Once you remove the
hypotension is
yeah, hypotension,
yes,
sudden decompensation also will be there.
yes, sir. Hypotension is
Hemorrhage may bleed into the ascitic fluid.
yes, sir.
Because these patients having a coagulopathy, right?
Yes, sir.
Okay, you continue presentation, please. Sir, you will continue the presentation. She has continue presentation.
Okay, sir.
Ah.
Sir, on day 1 investigations, hemoglobin is 9 gram per deciliter and hematocrit was 27%. Total WBC count 15,000 cells per cubic mm. Differential count neutrophils are high 90. Platelet count 75,000 cells per mm cube. ESR is raised 50 mm in first hour. RFT is blooduria and 40 milligram per deciliter and creatinine 1.1 milligram per deciliter. Calcium 7.8, magnesium 1.8, phosphorus 1.9, serum electrolytes, sodium 128, potassium 3.6, chlorides 92, prothrombin time 14, activated prothrombin time 41.
Can you go back the slide?
Go back.
Yeah. Okay. So
ANR,
no, go back. First, no, back. Investigations.
investigations.
Okay. Investigation. So there are almost all parameters are abnormal, including hemoglobin, total count and the platelets, sodium, okay, INR, everything. Can you explain each by each one? What are the coagulation defects you will see in the chronic liver disease? And why thrombocytopenia, why hyponatremia and hypokalemia?
Okay. Patient patient is taking alcohol, sir. Alcohol is one of the factor where alcohol directly causes destruction of the RBC and erythropoiesis reduction will be there, sir. So, and the patient is also malnourished. His poor oral intake is one of the cause for lowered hemoglobin, sir. And already he had past history of varicose bleeding 1 year back, sir. That may be one of the cause that baseline hemoglobin was low, sir. Sir, hematocrit 27% when patient is in hypervolemic state, so PCV was decreased. Patient is having features of peritonitis, counts were increased of 15,000, in which polymorphs are high. Platelet count 75,000 in liver disease patients. The thrombopoietin which is produced from the liver will be decreased. Hence, the production of the platelets will be decreased. So they have counts of 75,000. ESR in any infective state, ESR will be raised, sir. RFTs are seems to be normal. Electrolytes. Sodium 128, hypervolemic state of hyponatremia. Potassium is 3.6, seems to be normal. Chlorides 92, and abnormal coagulopathy. Coagulopathy which occurs in liver diseases, there will be decreased production of coagulation factors. So the coagulation
What are the
profile.
coagulation factors will reduce in liver failure?
Sir, in coagulation factors like 2, 7, 9, 10, except factor 8 and valve factor, remaining factors production will be decreased, sir, which is main thing which causes abnormal coagulation profile.
What are the
INR.
INR? What are the indication of raised INR?
INR is one of the parameter of prothrombin time, which the difference between the patient prothrombin time and the control prothrombin time to the power of ISI standards of 1.3 to 1.6.
Jasmine,
Sir,
in this the PT is 14, INR is 2.1. Is it correct?
prothrombin time normal is 10 to 11, no, sir, 11.5.
Okay, when his INR is prolonged, PT also will prolong.
Yes, sir. When it is more than 2 seconds prolongation, we'll take it as abnormal prothrombin times.
What are the causes of thrombocytopenia in the liver failures?
She told sarcopenia.
Thrombocytopenia, mostly thrombopoietin, which is produced from the liver, gets decreased in liver failure conditions, sir, which is the main feature, main thing for the platelets to get produced. So as thrombopoietin is reduced, the platelets also will get decreased, sir.
So when is the indication of
Yeah.
platelet transfusion?
Sir,
Jasmine, is it
usually
the production? Is it destruction? Thrombocytopenia is due to the production. Is it destruction? What Mohan Rao question is it reduced just because of production or a destruction? And also, thrombopoietin is
Sir.
produced from the liver or kidney?
Sir, erythropoietin from kidney, thrombopoietin from liver.
So,
Okay.
so both things will be there, sir. Production also decreases because of splenomegaly. There will be destruction also will be there. So one more question in the chat box, Jasmine, for you. What are the
Okay,
differential
sir.
diagnosis for SBP?
Main in cholestasis, cholangitis, tropical diseases, the presentation will be in the same way, sir. By in viral hepatitis also patient may have.
Sairama, can you unmute and comment on this one?
So usually you look at the neutrophil count, and if it is more than 250, you label it as SBP.
Rama,
And
she
if
told
the-
that. Rama,
yes.
told.
So the differential diagnosis is you have to differentiate it with the perforation sometimes, wherein you find multiple organisms and the count is very high in these cases. Or tertiary peritonitis. It is secondary peritonitis, tertiary peritonitis, and spontaneous bacterial peritonitis. These are the differential diagnoses for SBP.
Okay.
Okay, next slide.
Next slide.
Blood group typing is O positive, sir. Liver function test, total bilirubin is 9, direct bilirubin is 6. Enzymes like SGPT is 292 and SGO2 383. Total and alkaline phosphatase is around 300. Total proteins are 4. Serum albumin 2.2. Arterial ammonia scent. Amylase 60 units per liter and lipase 50 units per liter. Serum LDH 600. Viral markers like HIV, HBsAg, HCV are negative. Scrub typhus, dengue, QBC for malaria parasite are negative. ABG showing metabolic acidosis.
So here, what are the enzymes produced from the liver?
Sir, enzymes normally hepatic liver parenchymal function will know by SGPT and SGOT. Sir. In obstructive pathology, will monitored by alkaline phosphatase, 5-nucleotidase, gamma glutamyl transaminase.
From where they produce? Alkaline phosphate and GGTP secretes from where?
From a liver parenchyma tissue only, sir. But in obstructive pathologies, this will be
from the biliary system.
biliary connect.
Not from the hepatocytes. Okay.
Yes, sir.
Next.
So, Jasmine, I have a few questions for you from this slide. So,
Okay.
by seeing the direct total bilirubin, how can you differentiate between whether it is a hemolytic jaundice or a hepatic jaundice?
Sir, in hemolytic jaundice, we usually have indirect unconjugated bilirubin will be high, sir. In hepatic jaundice, mostly conjugated bilirubin will be, both may occur, but mostly we will go for conjugated direct bilirubin. Yes.
In this investigations, the alkaline phosphatase in this 300, is there any significance? No, this liver failure SGO SGPT will elevated. What about alkaline phosphatase?
Alkaline phosphatase was also elevated, sir. But patient doesn't have any obstructive features presentations.
So in a pulmonary hepatic failure, where the very high amounts of enzymes will elevate, and in alcoholic liver disease, how much times these enzymes will elevate?
Sir, in alcoholic disease, there will be more than 300. Sir, in viral hepatitis, those will be more than 1,000.
In which
1,000
condition enzymes will be very high, I mean 10,000, 12,000?
In viral hepatitis, mainly in viral hepatitis only, will have higher.
Any other condition? What is shock liver?
Shock liver is when the perfusion completely stuck in this or when perfusion to the entire organ was decreased, will in conditions like obstruction, main vessel obstructions will.
In which condition you will see that?
Butchery syndrome is one of the main septic shock.
Septic shock will you see 1,000, 10,000? In which condition you will see very, very high enzymes. HCOT, HCPT will elevate.
Acute fatty liver of pregnancy, sir.
No, in a shock liver like ischemic hepatitis, in case of severe RV dysfunction, severe LV dysfunction, and cardiogenic shock, patients will be going into shock liver or ischemic hepatitis. That in that case, enzymes liver will be congested and the patient will be developing very high amounts of HCOT and SGPT levels. Okay.
Okay.
So it will be reversible once the cause etiology, the cause is eliminated, then it will turn to the normal. But in alcoholic hepatitis, there is a moderate elevation of the
Elevation.
enzymes. Continue.
Jasmine, why did you send arterial ammonia for this test for this patient? Is there any
Sir,
significance, and is there any will you take any precautions while sending the sample?
Sir, patient is having a confused state. So to check for arterial, as patient presenting in encephalopathy, we have sent arterial ammonia, sir. Arterial ammonia is diagnostic when compared to venous, sir, because the levels of ammonia will be high in arterial blood when compared to venous blood.
What he is asking, what is the difference between the arterial ammonia and serum ammonia? Why you prefer serum ammonia, arterial ammonia?
Is there, do you take any precautions while taking the sample? Immediately we had to keep the sample in the ice box and we had to send to the lab immediately. Otherwise the results will be enormous. Other thing is, Jasmine.
Hello, Jasmine. Hello? Jasmine. Sir, sir, sir.
Disconnected.
Jasmine.
Yeah, Jasmine.
Screen share చేయమా.
Yeah.
Sir.
Coming to the viral markers, which test
Okay, sir.
send for the HCV diagnosis? Just you wrote HCV negative.
Yes, sir. Anti-IgM HCV antibodies, sir.
Good, good.
Hepatitis
Yeah.
Hepatitis B.
Sir.
Core antigen.
Sir, sorry, sir.
Okay,
Sir, sorry.
Continue.
Okay, okay,
the
sir.
ABG. Okay, go back.
Okay, 1 minute, sir. 1 minute, sir. Sir, with this clinical scenario, patient is presented with fever, thrombocytopenia, elevated liver enzymes, and what are the to rule out the infective etiology, you send the scrub, dengue, malaria. Jasmine,
Yes, sir.
apart
Yes,
from
sir.
that,
Yes.
any another infections do you want to rule out? Fever, thrombocytopenia, elevated liver enzymes.
Hepatitis C and hepatitis C.
Any other tropical condition
Other job.
infections, you will see the thrombocytopenia and jaundice, raised LFT.
Leptospira, sir.
Yes, correct.
Yes, very good.
Leptospira, you will see the
Leptospira.
yeah. Because patient is from the village and it is also one of the
Yes.
common in India. And
Okay,
coming to the ABG, what is your diagnosis on ABG?
ABG is showing metabolic acidosis, sir.
Can you evaluate properly ABG?
Sir, pH is around 7.34 and bicarbonates are 13. Mostly it is going towards metabolic side, and for PCO2 compensation 1.5 into bicarb plus 8 or plus or minus 2, according to that formula, we'll get around 26 to 29, sir. That is compensation was also corrected, sir. So it is
So you will see metabolic acidosis and alkalosis.
Yes.
So continue.
Lactates are high. Procalcitonin, blood culture sensitivity, urine culture sensitivity, ascitic fluid culture sensitivity, Gram-Stein were censored. Ascitic fluid analysis showing differential count of polymorphs 400, LDH 500, proteins 1.3. Gram-Stein showing gram-negative bacilli are present, sir. Serum ascitic albumin gradient is 0.9, sir.
This is actually once the 0.9 that will not come to the SPP. Okay, it should be more than 1.1. Okay.
Okay.
Right.
So yeah.
Carry on.
Chest X-ray was done, sir, showing normal. Ultrasound abdomen has features of hepatomegaly, irregular outline liver surface, splenomegaly, and moderate ascites. Echo was done, sir. Echo was normal with ejection fraction 60%.
So Jasmine, with your clinical history and clinical findings, so where do you finding the focus of infection?
Sir, it is a bacterial peritonitis. Sir, can you repeat the question, sir?
So under means focus of infection is you're suspecting abdomen.
Yes, sir.
So then actually you send all the pan cultures, blood, urine, and ascitic. Okay, blood
yes,
we can
sir,
accept. Urine it is needed. Just for the exam point of view, they will ask, is there any urinary symptoms?
Patient is not having urinary symptoms, sir, but in sepsis screen to rule out, we have sent, sir.
Yes, it is very important. Actually, in liver disease, acute decompensated liver disease, you have to rule out all other infections, the source of infections, because the surveillance and antibiogram is very important to select the antibiotics, or surveillance of the sepsis in chronic liver diseases.
Yes, sir.
Even it can rule out the pneumonia, because the patient is having low albumin and low immunosuppressive. These patients nutritionally is very poor, and these patients can develop any other organ infections. So
Yes,
even
sir.
other organ infections also the source for decompensation.
Okay, sir.
Okay, next slide.
Management. Patient was RT was placed, and we started IV fluids DNS of 75 to 100 ml per hour. RT feeds started 25 ml per hour. Antibiotics third generation cephalosporin, cefatoxim 1 gram IV BD started. Injection pantoprazole 40 mg IV OD given. Vitamin K 10 mg intravenous OD was given. Thiamine 200 mg BD was given. Albumin 1.5 gram per kg per day. Lactulose 30 ml through Riles tube QID was given. Tablet ursodeoxycholic acid 300 mg through RT BD was given.
Okay. What is the role of albumin infusion in CLD patient?
Sir, albumin mainly it's an plasma expander where it draws the fluid from interstitium intravascular component. These are states of as patient will be in a hypervolemic state, albumin has a role in drawing the fluids. In
So it will affect on a mortality.
Intravascularly, so it retains the fluids.
Will it affect the mortality?
No, sir. No, sir.
Hello? So how much albumin will you give?
Albumin usually on day one will start with 1.5 gram per kg per day, sir. Or from day 3, we'll give 1 gram per kg per day, sir. Up to 100 grams we can do, sir.
So why you want to give thiamine? What deficiency patient will develop? Nutritional deficiency, vitamin deficiency patient develop in alcohol liver disease.
Patients will have a Wernicke's encephalopathy, sir, in thiamine deficiency. Mainly patient.
Do you differentiate Wernicke's encephalopathy and hepatic encephalopathy?
Sir, hepatic encephalopathy pathogenesis is due to the ammonia, which causes effect on the brain cells, sir. In Wernicke's encephalopathy, it is mainly due to thiamine deficiency. Where there is in alcoholics, there will be poor absorption of the thiamine, which results in the features like ophthalmoplegia, ataxia. Main gluconeogenesis is the pathway where the pyruvate should enter the Krebs cycle, where thiamine will act as a cofactor for entering. So if we don't supplement the thiamine, the anaerobic metabolism will be high, sir, where pyruvates will be converted into the lactates, resulting in acidosis again.
What is the pathophysiology of hepatic encephalopathy?
Hepatic encephalopathy mainly the in disorganized liver function, the main urea detoxification of ammonia in the form of to conversion to glutamine and urea cycle will be disrupted, sir. So the ammonia levels in the blood increase. These have a toxic effects on the astrocytes, resulting in the swelling of the cells and degeneration of the cells, resulting in encephalopathy, sir.
So what is the cause of encephalopathy in acute liver failure, pulmonary hepatic failure, and what is the cause of encephalopathy in chronic liver disease?
In acute liver failure, mostly the toxins or the drug effects will be the main causes affecting, sir. In chronic forms, already decompensated liver cannot eliminate, detoxify the ammonia, resulting in increased ammonia, resulting in encephalopathy.
CLD, ammonia is the cause of the encephalopathy. But what
Yes,
about pulmonary hepatic failure? What is the cause of encephalopathy?
Maybe the virus, maybe due to the drugs,
Cerebral edema.
toxins.
Cerebral
Cerebral-
edema is the cause of encephalopathy in permanent or acute hepatic failure. There is the
Okay, sir.
cerebral edema. Here is the ammonia. So the root cause is ammonia. You have to reduce the ammonia by various measures. And in acute pulmonary hepatic failure, you have to reduce the cerebral edema. That is the cause of encephalopathy, grade 4, coma. Patient will go into coma. So
Yes,
unless
sir.
you treat, unless you identify the measure the intracranial pressure and reduce the pressures, then otherwise
Yes.
we are going to coma, coning, and brain death. So it is very serious. Pulmonary hepatic
Yes, sir.
failure. The cause is cerebral edema. Here the cause is ammonia toxicity. Okay.
Yes, sir.
So how this lactulose will reduce the ammonia levels?
Lactulose is a non-absorbable oligosaccharide, sir, which where in it causes a purgative. Mainly, it decreases the colonic pH. It decreases and it causes purgative effect, preventing the absorption of the ammonia, sir. Dose of about
Conversion of the ammonium to ammonia.
yes, sir. Prevents the absorption.
And absorption. So it
Yes,
prevents
sir.
the conversion and reduce the absorption, right?
Yes, sir. Yes,
What
sir.
are the antibiotics you will use for the same purpose?
We'll use neomycin and rifaximin, sir. Rifaximin of dose 500 mg BD, sir. 550 mg BD, sir. And neomycin we'll give 500 mg TID, sir.
It acts. How it reduce the ammonia?
They're also the same action preventing the absorption of ammonia, sir.
Why antibiotic?
The gut, they are which ammonia production there is by the gut bacteria. To combat that, we'll give antibiotics, sir.
Yeah, reduce the gut bacterial flora.
Bacteria flora.
Prevent the conversion, right?
Yes, sir.
Next slide.
On day 2, the patient general condition was decreased, sir, with decreased sensorium, vitals, blood pressure 80/50 mm of Hg, heart rate increased 110 per minute, respiratory rate 30 per minute, temperature 101 Fahrenheit, urine output 40 ml per hour, and sugars are 98 milligram per deciliter. Stools passed 3 times, sir.
So there is a one question, Sai Raman. Do the serum ammonia levels correlate with the severity of encephalopathy?
No, sir.
Okay.
Only
Then how it correlates? If it is not, how do you calculate the severity of this?
Sir, when it is more than 150, the main features of ICH will be more, sir.
So, okay. It is not the levels, but it is the trend.
Not the
levels,
less
right?
trend.
Yes.
Yes, sir.
So even 800 or even 200 will the same effect, right? It is not.
Yes, sir.
The trend of ammonium higher levels will cause the. Yes. Continue.
On day 2 investigations,
Go back.
hemoglobin 8 gram per deciliter.
Go back. Go back.
Sir.
So this patient having hypertension, right?
Yes, sir.
So patient already decompensated, going into her worsening the sensorium, and patient went into shock, hypotension. So how will you manage this patient?
Yes, sir. Sir, first hypertension, it must be corrected by giving IV fluids with yes, patient is having sugars on lower side. I have given bolus of DNS of 500 ml. As still PP is not improving, as they are in a state of hypervolemic, we cannot dump fluids. So I started with minimal vasopressor support with noradrenaline, sir.
Will what IV fluid you will select? DNS?
DNS.
Patient is hypoglycemic, you will give DNS. What is the crystalloid fluid you will select for resuscitation of the patient in shock? DNS?
Shock. No, sir. In shock, will not give DNS, sir. In this patient, liver patient, there will be a state of
you can give you can give 25% exercise later, but patient in shock, what IV fluid you will select for resuscitation?
normal NS, sir.
NS, sir?
And
RL.
balanced,
Balanced
balanced.
slides.
Yes, sir. Balance
Not
also.
DNS or dextrose solutions. Okay. Okay. How much fluid will you give this patient? How much IV fluid bolus will you give this patient?
This bolus will give about 30 ml per kg, sir.
ml per kg. That means patient if 60, 180 ml, you will give 1800 ml.
In shock, will follow that, sir. In this patient, we cannot give that much fluid, sir. So I have started.
Hello. Then what type of fluid management will you give in this patient?
Sir, colloids can also be given, sir.
Colloids.
In shock.
Colloids will give in septic shock?
No, sir. In septic shock, we cannot give, sir.
What it will cause? What are the side effects of contraindication of colloids in septic shock? Why you should not give?
Sir, mainly AKI will result, sir. Acute kidney.
That is the main kidney injury is the main reason to avoid colloids in septic shock. Okay.
Yes, sir. Yes, sir.
Not don't mention colloids. Okay.
Okay.
Okay. Next, continue.
We started with intravenous fluid DNS of 500 ml bolus followed by 100 ml per hour. Still BP on lower side, we started vasopressors noradrenaline 4 ml per hour. RTPs increased from 25 to 50.
Can you explain the 4 ml per hour? What is the dose?
Sir, actually, we'll put infusion of 0.05 to 0.5 microgram per kg per minute, sir.
Okay, what is this 4 ml per hour?
We'll
Is it 0.05
take
or
2 amp.
0.1? What is the dose? How many ampoules you added? 1 ampoule or 2 ampoules noradrenaline?
2 ampoules, sir.
The 4 ml comes to how much dose?
8 mg and 50 ml NS will dilute, sir.
No, I'm asking what is the dose exactly?
0.05 to 0.5 microgram per kg per minute.
No, I'm asking you are telling 0.05 to 0.1. What is this dose? 4 ml? Comes under?
According to the, okay, that will calculate, sir, based on body weight.
Okay, leave it because you have to tell the in micrograms. This much micrograms per kg per hour, not like 5 ml per hour, 10 ml per hour like that. If you mention 10 ml per hour, you have to tell the examiner that this is equal to 0.2 micrograms or 0.1 micrograms per kg per minute like that. Okay. Don't tell
Okay,
this,
sir.
this type of this orders will give for sisters. Okay. For examination purpose, 4 ml, 5 ml is not the correct. Okay,
Okay, sir.
1 ml,
sir.
that means 1 ml contains how many micrograms of your dilution? It contains 80 micrograms for 1 ml. That means you are giving a 4 ml. 4 ml into 80, 320 micrograms.
320 micrograms.
Means
Yes, sir.
you are telling about 8 grams, not the actual drug is only 4 milligrams only. That will
Yes, sir.
divided by 4,000 by 50. It comes about 80 micrograms per ml. 320 micrograms per hour. You are giving for ml.
Okay, sir.
Means by divided by 60 by divided by another 60. That comes how many micrograms per kg you are giving. Like that you tell what Dr. David question is like that. You tell in a per minute per kg.
Micrograms per minute.
Okay.
Okay, right. RTPs, continue.
Artifacts 50 ml per hour, sir. As potassium was low, around 3, we have given 40 milliequivalents correction of potassium chloride, sir. Antibiotics, we have changed from ceftazidime to piperacillin plus tazobactam, 4.5 gram.
From ceftazidime to peptaz, what is the rationale behind this? In one day,
Sir,
one day, patient not even 24 hours, second day itself you have changed the antibiotic.
sir, as a patient, general condition is
What is your
deteriorating.
suspicion of organism likely to develop the SPP? So you should know what are the Enterobacteriaceae. So
Yes, sir.
Enterobacteriaceae of various organisms include E. coli,
Ha-
Klebsiella,
Has a group.
as a group. Okay,
Has a group.
Enterococci,
Yes, sir.
staph, all the Enterobacteriaceae you should know to cover the likely organisms to having the septic shock. So
Yes, sir.
patient is gone into septic shock, hypertension. Then you already send the cultures. Okay, your procalcitonin is elevated and the counts are elevated, right?
Yes,
Then
sir.
you have to start the antibiotic or escalate the antibiotic to cover the Enterobacteriaceae, right? Patient might
Yes,
be
sir.
having previous admissions and immunocompromised patient. So this patient may be high chances of developing the ESBL, E. coli and Klebsiella. In ESBL, E. coli and Klebsiella, these patients may not respond with your BL-BLI groups. Okay. So
Okay,
while
sir.
selecting the antibiotic is very important. Antibiogram depends upon the underlying patient condition. How many admissions he has, what are the previous admissions, what is his general condition, hemodynamic status, nutritional status, everything, and previous antibiotic status, because these patients repeatedly come into the hospitals and admit. Okay. For antibiotic
Yes, sir.
selection, you have to give proper explanation why you are putting the antibiotic initially and why you have changed it to another antibiotic, and what are the likely organisms, bacterial, when these patients will develop fungal infections. Do you cover first day or second day itself fungal, antifungals?
Sir, first, not.
Hello?
Hello, sir.
Can you put antifungals at the first day of admission or second day when patient is having hypertension?
No, sir.
Why?
But on when we start antibiotic, if a patient is not improving and still in he's going to shock, then we can add.
I am asking patient has already developed shock. Okay.
Then we can add, sir.
Second day, can you add antifungal along with this Tazac? No,
We can add, sir.
you should not add because The fungal infections will be in second or third week, not in the first week of it. Okay.
Okay, sir.
So in SPP, bacteria, enterobacteriaceae is the most common cause. So you have to treat the bacteria, antibacterial drugs, not the antifungals. Okay.
Okay, sir.
You continue.
Yes, Jasmine,
Sir,
you escalated the antibiotics from cephalosporins to piperacillin tazobactam, which belongs to which group of antibiotic?
monobactam, sir, tazobactam, sir. Piperacillin, penicillin group of drugs, sir. Amido penicillin, sir.
Yeah, this is called a beta lactam and beta lactamase inhibitors. So before
sir.
you starting, you should know the which group of antibiotic you started and what organisms it covers. What organism it doesn't covers. Can you tell me which
Yes.
what organisms it covers? Piperacillin tazobactam.
Sir, it covers gram-negative organisms like E. coli, it will cover, sir. Both the gram-positive and gram-negative coverage will be there, except MRSA coverage will not be there, sir.
Also, before upgrading your antibiotic, you should you started empirically because you are waiting for the cultures, right now, Jasmine?
Yes, sir.
So then you have to see the your hospital antibiogram also. Which antibiotic the most of the patients are responding, then you can start. So what are the other beta lactamase inhibitors? Do you know?
Sir, ampicillin sulbactam. Next,
Commonly used in ICU.
amoxicillin clavelnate.
Most commonly used in ICU, BLBLA. Other than this,
Amoxicillin and clavulanic acid combination, sir.
regular ga వాడేది most commonly used in ICU. BLBLA.
Ampicillin sulbactam.
Ampicillin sulbactam వాడతాం అమ్మా రోజు.
What is magnamycin, amma?
Ah.
Magnex sport.
Magnex sport. What it contains?
Ciprofloxacin and sulbactam, sir.
Ciprofloxacin, sulbactam. Okay. These are
Yes,
the
sir.
most commonly used and FDA approved BLBLA group, not the meropenem, sulbactam or other groups. Other groups we are not approved by the FDA. And mostly majority of the people, this drug companies coming with the non-approved fancy BLBLA groups, which are not validated, and we should not use unnecessary combinations, right? Okay.
Okay, sir.
Great. You continue. Time is getting. Okay. Next slide.
Sir, on day 3, patient general condition improved, sir. Patient became conscious, coherent, vitals, blood pressure 110/70 mmHg without noradrenaline support, heart rate 90 per minute, respiratory rate 23 per minute, temperature has come down to 99 Fahrenheit, urine output improved to 75 ml per hour, sugars are around 120 mg per dl, passed stool for 3 times.
Next.
Investigations, hemoglobin dropped to 7.5, WBC count 17,000 cells, differential counts, neutrophils are high, platelet count 70,000 cells, electrolytes sodium 135, potassium 4, chlorides 102, liver function tests, bilirubin has started a decreasing trend of total bilirubin 4, direct bilirubin 2.5, SGPT of 120 and
at this stage 7.5 grams per deciliter. What are the guidelines? Blood transfusion in acute chronic liver disease.
Actually, we don't give blood transfusion at this stage, as the patient is not having any bleeding manifestations. As we have seen dropping, we have sent a stool occult blood at this stage, sir, but it has come negative.
So if this patient, suppose this patient is bleeding, massive varicose bleed, and
Yes, sir.
hemoglobin is 7 grams. Okay,
Yes, sir.
come to the ICU.
Yes, sir.
So what you will do? How will you manage the patient?
First, we have to plan for endoscopic for band ligation, sir, as if there is a source of ongoing bleed. So,
ABC, first ABC, first ABC.
yes, airway, breathing, circulation will secure an IV line, sir. We'll start with the IV fluids and depending upon the condition, coagulation profile also will plan for FFP's transfusion, and then we'll go for in endoscopic
What
procedures.
is the time limit for endoscopy? When you will do endoscopy in bleeding varicose?
After 48 hours, sir. Minimum
After
48 hours.
For 2 days, you will wait for endoscopy for
Yes.
ligation. The patient will
No, sir,
crash.
one day,
Not to-
24 hours.
No, we have to schedule for endoscopy within 12 hours. Okay. After correcting the coagulopathy. And what is the
Yes, sir.
hemoglobin levels before you go for endoscopy?
Normal hemoglobin.
No. What hemoglobin you will see before you go for endoscopy? At what level you take for endoscopy?
Around 8, sir.
8 is the limit. So
Yes, sir.
non-bleeding patients, 7 is the limit. Okay. And in a
Yes,
bleeding
sir. Yes,
patient,
sir.
varicose bleed, you have to give blood transfusion, FFP, other any coagulation defects, and then go for a procedure like endoscopy or either any invasive procedure. That will be 8. Okay. And within 12 hours, we have to set for
Okay.
endoscopy, not 48 hours. Right. Carry on. Next slide.
Yes. Next, we managed with IV fluids we decreased IV fluids, sir. RT feeds increased to 75 ml per hour. We continued the same antibiotic, pantoprazole, vitamin K, thiamine, albumin of 1 gram per kg per day. Also, deoxycholic is considered. We added spironolactone 25 mg RT-PD, sir. Lactulose 30
What is
ml.
the
Right.
spironolactone and why you advise spironolactone in patients with CLA?
Sir, spironolactone is a potassium oral. First, oral diuretics are preferred, sir. As IV
Spironolactone
diuretics
actually.
will cause potassium sparing diuretics, sir.
Taxa.
Potassium, sir. Potassium is very important where potassium will increase glutaminase activity, which prevents the formation of the ammonia, sir. So indirectly, the potassium sparing potassium levels maintenance will improve
potassium.
the
Any other action of the spironolactone?
edema will be decreased, sir, and diuretic effect will be there, sir.
What is other effect? So it is a aldosterone antagonist. Okay.
Yes, sir.
So
It increases
hyperaldosteronism will be there in the chronic liver disease that causes hyponatremia and water
hyperkalemia.
hypokalemia and water reabsorption into the third space, and that causes dilutional hyponatremia, where the spironolactone will spare the as a diuretic, it will push the water out and spare the sodium.
And
So
retains
sodium will be retained and potassium will be retained. Okay.
Yes, sir.
So these two things we have to tell, not only potassium.
Okay.
And we have to carefully watch the electrolytes regularly. Patient will be going into hyperkalemia. Okay.
Yes, sir.
Right. Continue.
On day 4, patient general condition was improved. Vitals stable. Urine output 100 ml per hour. Sugars were 120. Investigations: hemoglobin 8 gram per deciliter. WBC count 15,000. differential count of neutrophils 80, platelet count 1 lakh, serum electrolytes sodium 135, potassium 4, chlorides 102, liver function test, total bilirubin is 3, direct bilirubin is 1, SGPT is around 50, SGO is 80, alkaline phosphatase is 100, stool occult blood report has come, it's negative. Ascitic fluid culture sensitivity showing E. coli sensitive to piperacillin plus tazobactam. So we continue the same antibiotic for a total of 7 days, and on the 2 days we have given blood culture sensitivity, urine culture sensitivity as sterile. We removed RT and we started the oral soft diet. Remaining drugs like pantoprazole, vitamin K, thiamine, albumin, ursodeoxycholic acid, spironolactone, lactulose. We continue, sir.
Next.
On day 5, general condition improved with stable vitals, stable urine output 100 ml per hour. Sugar. These are day 5 investigation. And
Continue. Next slide.
we started soft diet, sir.
Next, continue.
The last slide, sir.
Okay.
Is there any Jasmine? Is there any prognostic scores for assessing severity?
Yes, sir. We have we have scores like a child Turgot Pug score, MELD score, MELD Soldium score, next ARC score, next.
Yeah, we can divide like a general score like the SOFA score and Apache score, specific score. In this, what you told is ARC score. Did you calculate the ARC score for this patient?
No, sir.
Any algorithm?
Sir, ARC score includes 5 parameters, sir. Bilirubin, INR, lactates, creatinine, lactates, INR, creatinine.
Hepatic encephalopathy grading.
Hepatic encephalopathy grading. There are 2 types. Best Heaven grading and
no. This in the ARC score, the parameters you have to check is total bilirubin.
Yes, sir. Bilirubin, hepatic encephalopathy grading, and INR, creatinine, lactates.
So according to that, you can grade the mortality also.
We will check for the liver transplantation for this patient for liver transplantation. What are the indications and the contraindications of liver transplantation?
Sir, main liver transplant in acute liver failure conditions will go with King College criteria, sir, and Alfred criteria,
ALF,
sir.
acute liver failure. Like
in acute liver failure, sir.
Other conditions. Okay, in this case, acute or chronic liver disease with the type 1 HRS-AKI with
in acute this chronic liver failure, sir, will MELD score is based on creatinine.
What is the MELD score for choose for liver transplant?
Sir, MELD score is normally from 6 to 40 will give, sir. When more than 40 is a candidate for liver transplant. Usually of more than 21, patient is considered to be in a bad prognostic state.
Okay, what are the contraindications of liver transplantation?
In patient in severe infections, we cannot do, sir. Next, uncontrolled diabetics.
Control diabetes. You can control and you can send them. Is there any contraindication for diabetes for liver transplant? Brain death, cerebral edema, grade 4 coma, diabetes, and patient is in chronic. Okay.
Yes, sir. Yes, sir.
Any questions from the participants? Now is actually
Audience, please, you are requested to ask questions.
Srinivas, I think you put one question.
Really?
How do you arrive at the diagnosis of acute and chronic liver failure? Srinivas?
Sir.
How did you diagnose acute and chronic liver failure?
Sir, in acute on liver failure, patient will be having diagnosed liver disease or undiagnosed liver disease. Within 4 weeks, patient will land into either ascites or encephalopathy with previously hepatic disease of jaundice and prolonged INR. Sir.
What is portal hypertension?
Portal hypertension is one of the complication of cirrhosis liver, where there will be increased pressures in the portal venous system.
How much?
Portal.
How much pressure increase in the portal
More
pressure?
than
More,
more than 6, sir. 6.
no, once you read the acute or chronic liver disease, Jasmine, we have to. Portal hypertension is very, very important in cirrhotics, one of the complication, and this is 100% they will ask what is portal hypertension. When you will, how will you diagnose the portal hypertension? How will you treat the portal hypertension? Okay, what are the complications of portal hypertension? This is very
Esophageal
important.
varices.
Okay, so
Yes,
once the
sir.
portal pressure is gone up to how much level?
Then 12 mmHg, sir.
Gone up to 12 mmHg and
And
hepatic venous pressure. Hepatic venous wedge pressure more than 5 mmHg
yes, sir. Hepatic.
on the inferior vena cava. Okay.
Yes, sir.
If it is more than hepatic G, the inferior vena cava will be opening into the hepatic vena. You will see in the ultrasound. So the hepatic venous wedge
Yes, sir.
pressure, if it is more than 5 mmHg above the inferior vena cava and the portal venous pressure more than 12 mmHg, that is the portal hypertension. So what is the pathophysiology of portal hypertension?
Sir, when the liver become fibrotic, the pressures will be increased in the anastomosis will occur between the portal and systemic vessels, sir, resulting in complications like varices and hemorrhoids.
And how patient develop ascites?
Ascites, ascites mainly develops due to the hydrostatic pressure will due to increased portal venous pressure, the hydrostatic pressure will increase and results in the movement of the fluid into the extravascular components.
No, you are telling just like simply. It is not like that. The hepatosinusites will open and portal pressures will increase the resistance in the portal system, and the portal blood flow will increase. Then the systemic blood flow will increase because of the sinusites will open, and there is
Yes, sir.
already there is a splanchnic vasodilatation. Okay, blood flow will increase, though there is a altered Stalling forces, and the cardiac output will
Yes,
increase
sir.
very high. Once the cardiac output will increase, then there is a opening of this portosystemic shuts will open, then the patient fluid will accumulate in the peritoneal cavity. So these are the
Peritoneal.
cycle, the
Yes.
vicious cycle. We have to mention how, what the pressures, how it changes, all these things. Okay, and how
Okay.
this varicose will open, what are the How will you manage varicose bleed? Acute varicose bleed.
Sir, varicose.
Yeah, tell. How will you manage acute varicose bleed?
Varicose bleeding, octreotide or in doses of telepressin 1 to 2 mg IV boluses.
Huh?
Hello, sir. Sir, could you hear me, sir?
Yeah, tell.
Sir, telepressin of 1 to 2 mg IV boluses, sir. Next, octreotide of doses 50 mg IV bolus followed by 50 mcg bolus followed by 50 microgram per hour will continue, sir. Next, pantoprazole infusion also will continue for 8 mg per hour for 48 hours, sir.
What is the role of telepressin? How it acts?
Sir,
What is the role of telepressin?
telepressin is a vasoconstrictor, sir, where it constricts the vessels, resulting in decreased mainly vasoconstriction, sir.
Vasoconstriction in which vessels?
Splanchnic blood vessels, sir.
Splanchnic vasoconstriction. So,
Splanchnic vasoconstriction.
There is a question. There is a question. There is a question in the
there is a
chat box. David.
Mohan Maharaj is asking, we face the problem of stabilizing a patient with varicose bleed. So how will you stabilize by transfusion is the priority or endoscopic procedure is the priority? Patient come with varicose bleed. So to
First,
stabilize
we
patient,
should
what you will do?
sir, first we should see airway breathing situation should be maintained, and then we'll plan for endoscopic bang or stereotherapy.
I'm busy. Good. Okay, one patient is acute varicose bleed in shock, busy bleeding profusely. How will you manage this patient?
Sir, first there will be aspiration risk, so we should secure his airway, sir, and then we'll first stabilize with depending upon the hemoglobin levels, we'll transfuse blood products, sir, and we'll start octreotide infusion, pantoprazole infusion, sir.
What are the anticoagulants you will use? Sorry, procoagulants. Anticoagulantic drugs, procoagulants, what is the role?
Procoagulant, like vitamin K will give, sir, for increasing the coagulation factors.
What are
As
the
coagulopathy will be there.
What coagulation factors will be defect and what coagulation factors will transfuse?
Sir, 2, 7, 9, 10 are the main factors. Vitamin K dependent
Product of the
factors.
blood.
Sir?
It contains in which product of the blood? Blood products.
No, fresh frozen plasma, sir.
When you will give cryoprecipitate?
Cryoprecipitate, which contains fibrinogen, factor 8, and
how much cryoprecipitate will give? How much cryoprecipitate will give?
200 ml per hour will give, sir.
200 ml per hour. How many units will give?
10 units, sir.
Okay, this patient is profusely bleeding. He is already in shock, 75-40 BP. Okay, you stabilize the airway, and how will you arrest the bleeding? Patient is bleeding profusely. How will you arrest the bleeding?
Sir, will since taken a black tube can be used, sir, for the control.
What is the role of factor 7A in this patient?
Factor, recombinant factor 7 can be given when we want to prevent fluid overload, and if we want to correct, we'll go for factor 7, sir.
Sir, Mohanra, sir,
Yes, sir.
any final conclusion? Please.
Achyut, Dr. Achyut. So Anuradha has put on question. The surgeon is not available for the endoscopic procedure. Can we do any other thing for upper GI? Surgeon means not surgeon. Gastroenterologist is not available for doing the endoscope and EVL. So can you do any procedure to stop the arsta bleeding?
Already told, Jasmine already told
Thanks,
that
taken
mechanical.
Yes, yes.
Sir, thanks, taken
Mechanical.
vacuum or tube.
Okay, okay, sir.
One more question last, I think. What is the indication for FFP? At what level of INR you will give a FFP?
Sir, INR is a prognostic factor, sir. Depending upon that, we should not transfuse FFP, sir. Only when the patient is having bleeding manifestations, or if we plan for any invasive procedure, only we have to transfuse, sir. Depending upon the INR, only we'll prognify the patient.
No treatment.
What
Good.
is the
Yes, sir.
dose of FFP will give depends on the INR. Suppose INR 6, how much FFP will give? INR 4, how much FFP will give?
It's not depending upon the value, sir. Usually we'll give up about 10 to 15 ml per kg.
Will reduce
No.
how much INR?
No. How much correction? You should say how much will correct the one INR. Huh?
Yes,
There is
sir.
a formula is there, madam. Not like that.
Sir, formula.
Not approximately. It is not like a pinpoint, but
How many units will
approximately.
correct the one?
Yes. Approximately, each point of it means each 10 ml per kg reduce how much INR? Suppose INR is
Right.
0.5. So how much FFP will give to come down to 1.5? Because procedure is there, laparotomy is there, or some procedure is there. So just like you will give 10 ml per kg is sufficient. Okay, you read that. Okay, even all the coagulation abnormalities and severe coagulopathy. What are the abnormalities and how much each factor will transfuse? How much prothrombin complex? Okay. Complex will give, and what is the role of recombinant factor 7A? What is the role of fibrinolytic, antifibrinolytic like tranexamic acid? What is the role of vitamin K? All things it is very important. Okay. Once you start the presentation, the examiner will go into any beyond the case, any level. You go into antibiotics, will go into septic shock, will go into septic shock, deviate into that level. Okay, he will go into transplant, and he will go transplant related things, and he will go into. So you should be prepared to answer all type of questions and diversions. So you cannot fix to the liver. You have to read all thing about the liver, but you have to cover, have a knowledge of the entire. That is because final examination they expect you to answer for all the systems, all the areas. Okay. Then we go into ICP monitoring. How do you manage the ICP, and what is the normal ICP, and how to reduce the ICP? What measures you will use to reduce the ICP? So they will go into deviate it to any extent. So you have to be prepared in all, read all the systems at the final examination, and you are ready to answer all the questions, antibiotics, the infections, bacteria, everything, right? Okay. You have done very well and a good
Okay, sir.
presentation.
Okay,
You
sir.
need more to prepare. Okay, and I am requesting all the audience. Finally, you can say anything or any questions to ask Jasmine. Please, you are allowed to ask. You are advised to ask. What, sir?
Yes, sir. Jasmine, congratulations. Very nice presentations.
Yes.
I think
Thank you.
repeated asking also, no one put the questions in the chat box. I think we can conclude. Kuchalabu, sir.
Okay.
Hello.
Well,
Yeah, okay, go ahead. Yeah, conclude.
Conclude. Thank you, sir. 35 people are participants are attended for this thing. Next week also with same time with a different topic will come, and I request all the HODs of all the hospitals to encourage their students to actively participate in discussion and join for the meeting. Thank you, sir. Thank you, ISCCM, Dr. Mohan Mara sir, and
Next
Dr.
class,
Dr.
Dr. Soumya and moderator is Dr. Rani.
Okay. Moderator. From Medicover, sir?
Medicover, Dr. Soumya is taking respiratory system and Dr. Rani is going to be a moderator.
Thank you,
Thank
sir.
you.
Yeah, better at least 4-5 days nunchi you can spend a flyers. Better the people more.
సార్ అలాగే సార్ అందుకే 1 week ముందు చెప్పేద్దామని సార్
Flyers should పంపండి. Not a link 1 day before, but flyers should be sent.
అలాగే సార్
Okay, thank you.
thank you, sir. Mohan Mara sir and Kuchel Babu sir
థ్యాంక్ యూ డేవిడ్ సార్
for giving the opportunity to be a moderator. Thank you, Jasmine, once again for nice presentation. And good luck for your
Thank you, sir.
other examination. Thank you.
Thank
Thank
you.
you.
Thank you.